May I start? Yes, okay. Good evening, esteemed judges and my dear friends. Today I'll be speaking of some interesting insights that we've had in our research in Narayana Nethralaya. I have no financial disclosures. We know that 101 million diabetics are there in our country, and at least 21 million of them have already got sight-threatening diabetic retinopathy. So we are on the lookout for a definitive treatment for our patients. Vitreous biomarkers have already shown in previous studies that they can predict who can get the disease and who can be treated with what molecule. So vitreous sampling is rather difficult. It's a surgery, it's risky. You also have tear samples at your disposal. You have aqueous which can be collected during the surgery or during the first injection, and even blood. I mean, all diabetics really test the blood every other day for their sugar levels. So that's what came about with this BRIGHT study, where we wanted to look at all 4 samples, see how well the biomarkers correlate amongst these 4 samples in the vitreous aqueous serum tears or the VAST study. We also wanted to see whether they correlate positively and strongly. So 22 patients who were undergoing diabetic vitrectomy, the samples were done on the same day, all 4 of them were collected. This is in brief of how we went about with the study. In our in-house grow lab, we not only stored the samples, we segregated them and eventually isolated these biomarkers, both cytokines, chemokines, and all the other inflammatory markers. We looked at 53 biomarkers, out of which 48 were positive, and we used different quantifiers because one did not really suit all of them, and we found an absolute concentration at the end of the study. What we saw was that the protein concentration was highest in the plasma as expected, and we used something called as a normalization technique to make all 4 of them comparable. Now, if you look at the image on the left, you will see that the biomarkers from ocular fluids are grouping together as against that from the plasma. Now, hold that thought because that's rather important. We also use something called as hierarchical clustering, wherein we were able to cluster together those biomarkers that correlated better across the different 4 samples. If you see cluster 2, there is a good correlation there between vasculogenic and inflammatory biomarkers. Now, what we found interestingly is that 80% of them correlated strongly between vitreous and aqueous, which is extremely good news for us. And also, when you looked at all 4 samples, it was around 28%. This is a Sankey plot. This is very important because it shows the complex interplay between sample sources and the different biomarkers. The ones that are shown in red arrow are these here. These are the clinically relevant ones and potential drug targets. Besides the usual suspects of VEGF and angiopoietin 2, you see few other players there that are rather important, which are again pro-inflammatory biomarkers. Yes, to sample every patient for all 4 of these on a single day across disease spectrums was rather difficult. We need to keep in mind that systemic conditions can cause variability in these samples, but the test is repeatable. We are on the brink of potentially finding a target that can be better addressed, giving long-term benefits. This is the first study that compared 4 different samples. We saw an extremely good correlation between vitreous and aqueous. We saw a reasonable correlation with tears as well because of extraocular spillover. Now, this is important. We saw that organ-specific sampling, because of that grouping, seems to be a little bit more reliable than general body fluids. And then, friends, surrogate sampling is now possible through non-invasive or less invasive sources such as aqueous and tears. Let me show you with an example. This is a patient who's diabetic, was given anti-VEGF, and look at the response. He's not very, very happy. So we looked at his aqueous that was taken during the first injection. You can see that the VEGF level is rather low. Intuitively, we switched the patient to steroid and look at his resolution. Fantastic, isn't it? Now, this is another lady. She came to me and said, "Ma'am, I hate injections. You have to give me the least possible number of injections." We looked at a biomarker profile. Looking at this, you would say, "I think again, VEGF is low, ma'am. I think steroid would be a better option." We gave her a steroid and look at the response. Fantastic, isn't it? Imagine if you could get the same biomarker profile non-invasively, most easily, either from the tears or blood. The patient would be happy with less injections. I would be happy because she's responding well to a specific treatment. So friends, we are on the brink of a very, very bright future. We have a non-invasive biomarker that is repetitive. It can monitor progression for your patients, and it offers, most importantly, something called as bespoke or personalized therapy for patients. This is definitely going to improve their compliance. Dr. Gopal Pillai already spoke about eventually in the real world, you want to offer the best treatment for these patients for the best outcomes, and here we are. Thank you so much, friends. I thank my entire team for this support, and thank you, judges.
I think it's a really wonderful thing what you're doing, but All these interleukins, VEGF, they were all studied in your institute?
Yes, ma'am, 53 of them. We picked up the 53 most important ones because it takes a long time and a higher volume we need because, collecting the samples is challenging.
So it is all done in your biochemistry lab?
Yes, ma'am. We have a lab called as the Grow Lab. So we have our facilities to sample all of them.
Thank you.
Yes, thank you so much.